All right. So good afternoon, and thank you for the introduction. My name is Daewoo Kim from Cheongju, South Korea. Today, I would like to present a surgical approach using a press-fit rainbow block graft for maxillary implant rehabilitation. In particular, I will focus on how stable reconstruction can be achieved without fixation screws. Next, please. This work is based on our recent publication in the Journal of the Korean Association of Oral and Maxillofacial Surgeon. Rather than reviewing the paper itself, today I will focus on the clinical application and the biological concept behind the press-fit technique. Next, please. So odontogenic sinusitis often leads to persistent inflammation and progressive bone destruction. As chronic inflammation continues, alveolar bone resorption gradually progresses. As a result, the residual bone becomes insufficient for stable implant placement. In advanced cases, implant rehabilitation may become difficult or even impossible. Therefore, these patients present with two major issues simultaneously: infection and structural deficiency. For successful rehabilitation, both infection control and both reconstruction are required. Even if the infection is resolved successfully, the structural defect still remains. This is because the closure of the fistula alone cannot restore lost bone volume. Therefore, the real challenge is not simply closure, but functional rehabilitation. Next, please. So the key message is simple. Implant rehabilitation is impossible without bone reconstruction. Now, let me introduce the clinical case. Next, please. In this case, we have an oral antral fistula associated with severe bone loss. Conventional closure may solve the soft tissue problem, but it does not reconstruct sufficient bone for implant placement. Therefore, closure alone is not enough, and importantly, closure does not equal rehabilitation. And this is exactly the challenge we face in this patient. Next, please. Here's the case. This is 37-year-old male, presented symptoms associated with odontogenic sinusitis and had a severe posterior maxillary bone loss. Clinical and radiographic findings demonstrated sinus communication between the oral cavity and the sinus. So therefore, a staged reconstructive approach was required. Next, please. Our treatment goal was not simply defect closure, but to restore functional rehabilitation. The objective was infection control, bone reconstruction, and future implant rehabilitation. Next, please. So we follow a 4-phased treatment protocol. First, infection control was performed using incision and drainage, along with appropriate medication. Second, bone reconstruction was carried out using a press-fit Raymond block graft. After sufficient healing, implant placement was performed, followed by a prosthetic rehabilitation. So each phase was performed sequentially to achieve predictable rehabilitation. This staged approach is important because reconstruction should not be attempted in an infected environment. Only after infection control can predictable reconstruction and implant rehabilitation be achieved. However, conventional approaches still have important limitations. Next, please. Most conventional techniques focus primarily on fistula closure. Although soft tissue closure can be successful, bone reconstruction is often not achieved. As a result, implant placement remains difficult. To overcome this limitation, we applied the press-fit graft technique. Next, please. Okay, the press-fit technique has several advantages. Because fixation screws are not included or required, surgical invasiveness is reduced, hardware-related complications can be minimized, and the procedure becomes simpler. At the same time, primary stability can still be achieved, and you can maintain bone volume. So the question is, how can stability be achieved without fixation screws? The answer lies in the relationship between the graft and the surrounding cortical bone. Next, please. The cortical adaptation, tight cortical adaptation, minimizes micro movements and creates a stable healing environment. This is important because excessive micro movement can interfere with angiogenesis and early bone integration. This concept is similar to IVRO, where stability is achieved through bone contact rather than rigid fixation. In other words, stability comes from fit, not hardware. Next, please. This slide summarizes the overall concept of press-fit fixation. The process consists of defect preparation, graft insertion, and tight adaptation. The fundamental principle is that stability is achieved through precise geometry and mechanical interlocking. First, the defect is carefully shaped and standardized. This step is extremely critical because geometry determines how accurately the graft will fit. If the shape is irregular, stable insertion becomes difficult and less predictable. Therefore, precise shaping is foundation of this tool. Next. Graft is inserted from alveolar side towards the sinus. This direction allows controlled placement and helps maintain stability during insertion. Proper insertion also reduces the risk of graft displacement. Next. Finally, a tight fit is achieved. Next, please. Yeah. Between the graft and the recipient site. This close adaptation creates primary stability through mechanical interlocking. Therefore, stability is achieved through the fit itself rather than fixation hardware. Next, please. The primary closure is also important in this procedure. During the early healing phase, graft exposure can interfere with revascularization and bone integration. Therefore, tension-free primary closure is essential to protect the graft and maintain stability during healing. In addition, reinforcement using PRF and collagen membrane can further improve soft tissue healing and protect the grafted site. These materials help minimize complications and support predictable integration during the early healing phase. This principle is directly translated into the surgical procedure. The procedure consists of bone harvesting. Can we go back, please? Yeah. Press fit technique and soft tissue closure. Among these steps, the most important factor is achieving a precise fit between the graft and the recipient site. At this point, I would like to introduce a previous study using a similar concept of press-fit fixation. Although the surgical steps are not identical, the principle of press-fit stability is shared. For this reason, we use this study as a reference to support the feasibility of our approach. Next, please. First, a cortical block bone was harvested from the ramus area. The defect was carefully standardized and the graft was shaped to match the geometry of the defect. The graft was then inserted tightly into the defect, followed by primary closure. Next, please. So in this study, complete fistula closure was achieved successfully. Importantly, most cases were treated without fixation screws. These findings support the feasibility and the stability of press-fit concepts. Based on this concept, we applied a similar approach in our patients. Next, please. First, sinus infection was controlled through incision and drainage, along with appropriate medication. This step is essential because in chronic odontogenic sinusitis, the microbial environment shifts towards the pathogenic biofilms, including anaerobic bacteria such as Prevotella and Fusobacterium. This disrupts oxygen delivery and immune cell activity. resulting in impaired tissue regeneration and persistent inflammation. Therefore, the goal is to reduce the microbial load and establish a stable healing condition. After infection control, inflammation subsided and sinus environment became stable. At this point, healthy tissue conditions were established, allowing us to proceed safely to reconstruction. Next, please. Okay, this image showing IND. In this phase, a press-fit rainbow block graft was used to construct the posterior maxillary defect. Next, please. A rainbow block graft was harvested and carefully shaped to match the defect geometry. The graft was intentionally made slightly oversized to create a compressive fixation. The step is highly technique sensitive because even a small mismatch can compromise stability. Next, please. The graft was inserted without fixation screws using the press-fit technique. As shown here, tight adaptation created primary mechanical stability. Additional graft materials such as xenograft and allografts were applied to fill minor gaps and enhance volume stability. And PRF and collagen membranes were also applied to reinforce healing and protect the graft during the early healing phase. Then the primary closure was achieved. In this slide, next, please. Here we, after approximately 5 months, sufficient bone healing was observed. The grafts demonstrated stable integration with surrounding bone. At this stage, implant placement was performed successfully. Next, please. After 3 months of osseointegration, the ISQ values of 76 and 77 were recorded, indicating excellent implant stability. These values fall within range associated with stable osseointegration. These findings suggest that the reconstructed bone was both structurally and biologically stable. Next, please. So in summary, stable osseointegration was achieved. No recurrence of inflammation or fistula formation occurred. And most importantly, functional implant rehabilitation was completely successful. Next, please. However, careful surgical execution remains important. Potential complications include membrane tearing, flap descent, and inaccurate graft adaptation. In particular, membrane management is critical in this sinus environment because instability or graft exposure can compromise healing. Also, as this technique depends heavily on precise fitting, surgical accuracy is essential. Next, please. In conclusion, uh, infection control is the first and the most critical step. The press-fit technique can provide sufficient stability without fixation screws. Most importantly, this approach enables implant rehabilitation in challenging cases with severe bone loss. Thank you for your attention.
Good morning, and thank you to the organizers of the 4th International Webinar on Head and Neck Surgery for the invitation. My name is Alice Sapor, and I'm presenting on behalf of our team at Damascus University, Syria. Over the next 15 minutes or so, I would like to share our review on the use of terahertz radiation in oncology that is published in the Saudi's Journal of Oral Sciences. Putting it boldly, revolutionizing oral health care, and by the end, I hope that you will agree. Okay, so let me start with the clinical problem we are trying to solve. Oral lesions are common, and they are varied. They range from entirely benign growths to malignant tumors, fibromas, mucoceles, and different types of silicon, both to diagnose and to treat. And the way we treat them today, for the most part, is invasive. Surgical resection, diode lasers, radiotherapy, chemotherapy, all effective, but each come with real side effects and recovery costs for the patient. On top of that, much of our imaging and some of our therapies rely on ionizing radiation. X-rays do damage molecular structures, and repeated exposure can carry a measurable long-term risk of secondary cancer. So the question we ask, can we do this more precisely and more safely? This brings us to terahertz radiation. For those who don't work with it day to day, here is a quick orientation. Terahertz sits on the electromagnetic spectrum right between microwaves and infrared. Roughly 0.1 to 1 terahertz with wavelengths from about 3 millimeters down to 30 microns. Two properties make it interesting for medicine. First, it's non-ionizing, so unlike X-rays, it does not carry enough energy to damage molecular structure. Second, it is non-destructive, which makes it gentle. The trade-off is energy. A single terahertz photon carries only about 0.0413 electron volts, and that sounds tiny next to an X-ray. And it is, but I will show you when it is matched precisely to the right target, that low energy becomes the whole point. In oral healthcare, terahertz works along two frontiers. First is imaging, and that splits into passive imaging, which detects the natural terahertz emission of the tissue, and active imaging, which probes the tissue with a terahertz source. The second frontier is treatment, where the appeal is that it's non-ionizing, highly sensitive, allowing precise tissue-sparing therapy. Today, I will touch on both, but I will spend most of the time on the treatment side because that is where our review makes its main contribution. A quick word on where this evidence comes from because it shapes how much weight to give it. This was a narrative review rather than a single trial, and the real strength is that it sits at the intersection of three fields. From medical physics, we take the understanding of how terahertz behaves. From oncology, the behavior of lesions and what actually counts as meaningful treatment outcome. And from dental medicine, the oral pathology and the practical realities of dental implications. We brought those three perspectives together, grounded them in real data, peer-reviewed literature, and prior clinical trials and case studies. And the work reviewed and cleared by the ethics committee. So what follows is a genuinely cross-disciplinary synthesis protocol. The common lesions we addressed, the common oral lesions, are targets in oral medicine. A fibroma is a benign overgrowth of fibrous collagen tissue. A mucocele is a mucus-filled benign cyst. A periodontal cyst is an inflammatory overgrowth of squamous cells. A dentigerous cyst is developmental, linked to unerupted tooth. A root cyst osteonecrosis of the jaws is the death of jaw, often drug, trauma, or radiation induced. I am listing them deliberately because the key idea on the next slide depends on the fact that these lesions are not all the same on the molecular level. So the main idea here and in their paper is to target by dissociation energy. It is the core mechanism. The idea, the whole approach rests in. Every lesion has a kind molecular signature. To break the bonds that hold the tissue together, you need a specific amount of energy. We call that its dissociation energy. The chart on the right shows the values we've compiled for each lesion in electron volts. Notice that they are not uniform. A mucocele or a root cyst sits around 0.42 to 0.45 electron volts, but if a broma needs about 1.32 and the periodontal sits 3 times more. The difference is the opportunity. If we tune the terahertz photon energy to match the specific lesion threshold, we can disrupt that diseased tissue while leaving the surrounding healthy cells essentially untouched. Now, you will remember that a single photon only carries 0.0413 electron volts, far below these threshold. So in practice, we use amplification, and that is exactly what the treatment workflow does step by step. So here's how that plays out as a procedure. Step 1, we identify the specific lesion. Step 2, determine its dissociation energy, the value from the table we just saw. Step 3, we calculate the terahertz wave energy required to meet or just exceed our threshold. Step 4, and this is the engineering heart of it, we amplify the beam to the therapeutic power. Step 5, target the lesion with that precise energy. And step 6, monitor and assess the effects to confirm safety. The amplification techniques along the bottom are the ones that make 4 possible: parametric generation, optical rectification, or femtosecond pulses, quantum cascade lasers, laser plasma interaction, and pulsed laser methods. You do not need the physics of each one today. The point is this: the precision lives in matching the energy to the target, and the power to do it comes from amplification. This slide is really the safety argument, and it is one that I would ask the surgeons in the room to weigh in. On the left is a figure from the paper, the same region imaged with X-ray and with terahertz. The clinical contrast on the right: X-rays are ionizing, they damage molecular damage, and they carry risk of cell damage, burns, and hair loss. Number on it, a dose of 10 millisieverts, which is realistic across multiple CT scans, is associated with roughly 1 in 2,000 risk of fatal cancer. Terahertz, by contrast, is non-ionizing. There is no structural damage. The targeting is tissue-sparing, and to date, there is no documented harm to the human body for vulnerable patients, the ones who can least afford the downside of conventional radiation. To keep developing this. Before I close, a word on the diagnostic side, because terahertz is not only a treatment tool, it enables non-invasive, high-resolution imaging that evaluates dental health without harming the tissue. It is especially good at detecting early enamel caries, picking up decay before it's even visible on a conventional X-ray. It does this by sensing very small changes in water content and in the organic matrix of the enamel, and reading reflectance and absorbance to separate healthy enamel from carious enamel. And the potential reaches further still into assessing periodontal disease, screening for oral cancers, and evaluating dental materials. In other words, it's a step forward and genuinely proactive preventive dentistry. But also, we do have some limitations and open challenges. Here are the real limitations. And they are kind of significant. First, terahertz has limited penetration, which today restricted largely to superficial lesions. Second, it's strongly absorbed by water, and the mouth is a wet environment with saliva. And third, the low photon energy. That means that we depend on the matrix of the tissue that it holds. More affordable amplifications are not that good to amplify the photon energy as we wanted to target the tissues. Fourth, it interacts poorly with metal, fillings, crowns, and scatter. And they distort the signal. Fifth, the long-term safety, while promising, is not yet verified for chronic exposure. Sixth, there are practical barriers, high equipment costs, a shortage of trained operators, and a regulatory approval process that takes time. So, to bring it together, terahertz radiation offers precise lesion-specific targeting, makes it fundamentally safer than conventional radiation therapy. And it carries values on both sides of the clinic, in diagnosis and in treatment. What is needed next is clear, more efficient and cost-effective amplification, rigorous clinical trials on efficacy and long-term safety, and the standardized protocol backed by sound ethical frameworks. With that work, we believe terahertz technology has the genuine potential to transform how we approach health and oncology. Thank you very much.
I'm from Kemsha Dental College, Vadodara, Gujarat, India. Ma'am, there is some black line. Oh, okay, it is okay. So basically, the topic which I need to take today was the evaluation of C-reactive protein in patients with squamous cell carcinoma. As I have requested the organizing committees and the all the members that I just want to add my kind of them that they allow me to present on these two topics as well. So basically, this topic is my original research which we have conducted 2-3 years back, and now it has been published. And just today sharing my views on this article, what all features I have seen, what all things I have observed during this study. Basically, I'm sorry, low of oral squamous cardiology has always make me think that we should predict OSCC at earlier stage. Like we know there are various potentially malignant disorders that can help to diagnose early and to allow the patient not to go for this carcinoma stage. But there are certain various blood parameters that also we need to keep in mind while diagnosing. Next slide, please, ma'am.
Just a minute, doctor. We are working on it.
Okay, no problem, ma'am. So basically, I am going to discuss my paper only. That is, we will see introduction, aims, objective, material, method, then result discussion, and my conclusion and summary from the study. Next. Okay. So to start with, the global burden of squamous cell carcinoma in India is a huge. It's the most common cancer that affects males. It has now reached the seven most common cancer which are affecting total cancers in the body. So, to diagnose, to evaluate at early stage is of utmost importance in this case. The aim of the present study is to evaluate serum C-reactive protein along with hematological parameters in patients with squamous cell carcinoma, also to compare and correlate with the normal subject. Basically, the study was selected with the objective that I need to compare CRP level with various hematological parameters also. I need to correlate the association with various histological grading, and along with that, I am comparing various parameters, clinical parameters also, and the histological parameters also. Next. Okay. So to talk about the study includes 80 subjects, 50 patients with histologically proven oral squamous cell carcinoma, and 30 normal healthy individual as a control to compare the results. It's an institutional based cross-sectional study, and I have collected my data from head and neck surgical OPD and Gujarat Cancer Institute GCRI Ahmedabad, which is Asia's largest institute in Gujarat, that is Civil Hospital Ahmedabad. The inclusion criteria for my study was I have diagnosed the cases clinically as well as I'm taking histologically confirmed oral squamous cell carcinoma cases. Exclusion criteria I'm very specific to select because I know that just all parameters are affected by various systemic diseases also. So I'm taking proper history. I'm telling patient to bring their own reports. I'm taking proper history and I'm excluding the patient with any preoperative chemotherapy and radiotherapy, patient with any recurrence, patient suffering from any granulomatous disease like tuberculosis or sarcoidosis, anything. Patient suffering from any other malignancy before, patient suffering from systemic disease like renal failure, liver failure, cardiovascular disease, anything. I'm taking proper history. I'm taking patient and the subjects who comes to the OPD. I'm taking history and then I included those patients into the study. Next. Later on, the study, it includes material and method for the study. What I did is we have collected a venous blood. After collecting the blood in a two vacutainers, for CRP, we are analyzing serum. So we separated serum from that blood and I'm using this TurboLine CRP analysis kit to and run that sample in a colorimeter to get the CRP values. We have a mid-range analyzer in the institute, so it's an automated analyzer. So I'm just putting the blood in that analyzer and I got the hematological parameter on the screen shown. So this is how I am procuring my data. That is, I am getting CRP values as well as various hematological values from this. Next, please. After collecting the data, we have done the observation. We have taken the records that what all values I got, what all results I got, and I have put it into a table. Next, please. So to start with, first of all, I have divided my parameters. That is, when I am selecting hematological parameter, what I am more emphasizes is on the neutrophil and lymphocyte ratio. That is NLR ratio, which is already proven that the values are have a higher side towards oral squamous cell carcinoma, and I'm taking CRP. So for CRP, based on the previous literature, I have derived a value that group 1 will be CRP value less than equal to 5 milligram. Group 2, I am dividing the patients whose CRP value is more than 5 milligram per day. For neutrophil lymphocyte ratio, I have considered a median value as 2.31. So group 1 with less than equal to 2.31 and group 2 is always more than 2.31 value. And all the data has been analyzing using SPSS software, and it is done by chi-square and ANOVA test. Next, please. Okay. So this is my in-journal comparison of all the patients which I have taken into the study, that is 80 patients. In that, I have taken 50 cases and 30 control. So among this table, it has been shown that for CRP, the mean CRP value for oral squamous cell carcinoma is significantly higher compared to the normal individual of age-matched control group. When I talk about the hematological parameters, I have divided it into a three groups, that is RBC parameters, WBC parameters, and platelets. About the RBC parameters, we all know that the oral squamous cell carcinoma patient might be anemic somewhere, patient have less hemoglobin during that time, MCHC values are altered. So in that, what I get is MCHC value is statistically significant, so statistically significant difference between the cases and control. All the rest of the values are showing a huge difference, but that is not statistically significant. Among the WBC parameter, we have always seen that there is always a neutrophilia, there is increase in neutrophil count in squamous cell carcinoma patient when compared to lymphocyte reduced, that is lymphophilia. So in this study also, I have a statistically significant difference between neutrophils and lymphocyte count of cases compared to that of the control. For NLI ratio, of course, it is also statistically significant. When there is a tumor site, there are a lot of platelets aggregates over there surrounding the tumor site. So there is what obvious increase in the platelets value near the cases group. But this value, it's not statistically very significant, but yes, there is a difference between cases and control in this. And this table shows how the values of cancer patient differs to that from the normal individual. Next, please. Next, I have correlated various preoperative CRP values with the various clinico-pathological parameters. So the coaxis where I divided into a well-differentiated, moderately differentiated, and poorly differentiated squamous cell carcinoma. And the values show the statistically significant difference. That is, the patient with poorly differentiated squamous cell carcinoma shows higher CRP values and higher NLR values compared to that of the patient with well and moderately differentiated squamous cell carcinoma. The second parameter which I chose was the lymph node metastasis. In that, what I have seen is the patient with a palpable lymph node, which suggestive of a metastasis of the lymph node, shows a significantly higher CRP values and NLR ratio compared to the patient with non-palpable lymph nodes. When we see the type of the lesion, I have divided the type of lesion in the oral cavity based on the appearance as an ulcerative lesion, proliferative lesion, and ulceroproliferative lesion on the buccal mucosa or any of the site of the oral cavity. And among the three type of the lesion, what my observation is the ulceroproliferative growth shows a worsening of the values, that is the CRP values are more higher compared to that of the only ulcerative lesion or only proliferative growth. While NLR values shows a difference, but it was not a statistically significant difference. When we talk about the type of habit in India and especially in the Gujarat part of the India, the most common habit which people are doing is a smokeless tobacco, that is a chewing form of tobacco. And interestingly, chewing form of tobacco shows a statistically significant difference for CRP and NLR value. That is the patient who chews tobacco. Patient who chews tobacco have a more worsening value. The values are quite higher compared to those who are smoking, who use smoking type of the tobacco. And yes, I have taken the patient where they are doing both the type of habit. They have a smokeless tobacco habit also and non-smokeless tobacco habit also, and that also shows a significant difference among the values. The next is the duration of habit. Of course, if the patient who chews for more than 30 years, they have lot of toxins enters into their body, and that value are almost always going to change. And so I got a significant difference in the values among these two groups. When I talk about the frequency of the habit, some patients eats 1 to 2 packets per day for the tobacco, some 4 to 6, but more than 6 packets per day. I have got so many patients who chew tobacco for more than 6 packets per day, and that patient shows statistically significant difference in their CRP values and NLR ratios. Next, please. Ma'am, the top part is not visible. There is some, okay, it is visible now. Thank you, ma'am. So, what my idea is, I want to compare the histopathological grading of OSCC with mean CRP and NLR value. If you see the table, the chart which is there at the right corner, while we see a value. So from the chart, it has been seen that the mean CRP of poorly differentiated squamous cell carcinoma is comparatively higher. Same as if we see the NLR ratio, the NLR ratio is very high for the poorly differentiated cases. Next, please. If we see the association of CRP with that of NLR in patients with OSCC, what the observation we see is there are palpable and non-palpable type of lymph nodes which we have observed. Among that 36% of palpable lymph nodes shows mean CRP of 24.16, which is very much higher CRP values compared to those which are having a non-palpable lymph nodes, and that shows statistically significant difference. The value also shows that the palpable lymph nodes have a higher NLR ratio compared to the patient with non-palpable lymph nodes. And it is well seen in the chart given, the lymph node status of mean CRP values and mean NLR ratio. Next, please. So to discuss, I have divided my discussion part into two sections. That is, first CRP, next is hematological parameters. So for CRP, there are various studies already has been done in the past. They have observed this in the table. I have mentioned all the studies which recently has been done, and they have published also. One of the study by Anand Kumar et al. What it says that they took 50 patients and they compared with the grading of dysplasia, and what is their observation is severe dysplasia cases, the CRP values are significantly higher compared to other grades of dysplasia. Another study in which they have taken a tumor, they have taken clinicopathological parameters, and their studies also uh, concurrent with the present study which I am presenting. One of the study by Khandelwal et al., where they checked the lymph node status and the CRP values, and they got a significant result, which is contradict to the present study which I'm presenting. Next, please. For the hematological parameters, we have divided into RBC, WBC, and platelet. Among them, most of the studies are concurrent with our study as they observe decreased level of MCV, MCH, MCHC value. For platelet also, there are positive correlation with the various values. They shows increased PDW in the lung carcinoma patient also, which is also same for the oral squamous cell carcinoma. For WBC parameters, NLR can act as a biomarker for host systemic condition, and there is always a neutrophilia and relatively lymphopenia is noticed. There is an increased operative NLR in OSCC patient compared to a healthy individual as stated in 2019 by Flurari et al. I also want to mention that as I am seeing a lot of histopathological slides of porous squamous cell carcinoma, we see lot of neutrophilic infiltration around the tumor. We see lot of lymphoplasmacytic infiltration around the tumor, and that decides the prognosis of the tumor. So we should consider that as an important parameter also to when you are writing any report or when you are seeing any slides. Next. As we end towards the conclusion of the study, first I need to highlight few of the limitations, but I just want to mention that it's my ongoing research project. I'm still collecting lot of data as I know the sample size is comparatively low. So I'm adding more of the patient data. Right now I have a database for big number of patients in this, but I just want to emphasize here that we should take note from hematological parameters also. We should include CRP as an important pre-operative diagnostic marker when we are treating patients with oral squamous cell carcinoma. As it is a center study, we can always expand this study by taking all the samples from various institutes as well as My study is just a case control study. I'm not taking the data every 6 months, 12 months. So I can just change my study into prospective study. I can follow up that patient for longer time to get a more precise data and to check whether CRP is actually a prognostic marker also apart from the limitations for my study. Further studies are already going on from my side, and I in the future I will be publishing their article with more database on this. To conclude, CRP and hematological parameters serves as an important evaluation marker for the patient with oral squamous cell carcinoma. Therefore, multicentric with large follow-up duration and a large sample size is required in the future. Point here comes into how this will be helpful to the all the surgeons or all first and foremost, what I feel is when we check the blood report of the patient, specifically when we are suspecting oral squamous cell carcinoma in such patient, when we are seeing the value, this thing we should keep in mind that NLR ratio we can see because we can just predict that this patient might be getting a severe metastasis. This patient might be having a more destructive grade of dysplasia. So that's how we can at least give some prognostic indicator to the patient. We can, as it's a small parameter, we cannot leave the small thing by diagnosing the big lesion into the patient's mouth. So this might be helpful as a good marker to evaluate the disease. Next. These are my references. Next. Next, please. Thank the organizing committee for allowing me to present my research article at this platform. Thank you so much, everyone, for the patient listening and for allowing me to present. It's a pleasure to be here. Thank you.
Good afternoon, everyone. First of all, thank you to the examiners, the lecturer of this opportunity. My name is Gali Prasti Ayuskarningrum, and today I'm going to present my research titled Effectiveness of Bamboo Charcoal Extract Against the Growth of Streptococcus mutans. Let's start with the background. Dental caries remain a major oral health problem in Indonesia, affecting more than 50% of the population. One of the primary bacteria responsible for this is Streptococcus mutans, which initiate plaque formation and tooth demineralization. To address
Sorry
this,
to disturb you. You are not visible, Gali.
okay.
Yes.
One of the primary bacteria responsible for this Streptococcus mutans, which initiate plaque formation and teeth demineralization. To address this, there is an increasing interest in exploring natural alternatives such as a bamboo charcoal, which is widely believed to have antibacterial properties. Based on that background, the study aims to answer the specific problem: how effective is bamboo charcoal extract at concentration ranging from 12.5% to 62.5% inhibiting Streptococcus mutans. Therefore, the objective of this research is to evaluate its inhibitory power and determine the most effective concentration. For the material, we use bamboo charcoal derived from patung bambu, Dendrocalamus asper, which is known for its high carbon content. The target pathogen case was Streptococcus mutans strain ATCC 25175, a standard compositive bacteria found in dental plaque. Moving on to the methodology, the bamboo charcoal was extracted using the maceration method with 96% ethanol for 72 hours in the third condition. The extract was then diluted into 5 different concentrations: 12.5%, 25%, 37.5%, 50%, and 62.5% in using DMSO. Finally, we use the disc diffusion or Curie-Bayer method to measure the zone of inhibition. The study was conducted as a laboratory experiment using a completely randomized design testing step. The process involved preparing the Muller-Hinton agar media, inoculating the bacteria, placing the saturate with the extract, and incubating them at 37 degrees Celsius for 24 hours. The summary of result now. Interestingly, the data showed a 0 millimeter zone inhibition across all taste concentration. This means that from 12.5% up to 62.5%, the bamboo charcoal extract was found to be ineffective in inhibiting the growth of streptococcus mutans. As you can see in this comparison table, while the positive control, chlorhexidine, 0.2%, showed a clear inhibition. So, zone of 1,050 centimeters, both our negative control as a DMSO and all the extra group showed zero inhibition. Why this happened? Based on analysis, it is highly likely due to the degradation of bioactive compounds. Bamboo charcoal goes through a carbonization process at the temperature exceeding 300 degrees Celsius. This extreme heat degrees causing crucial antibacterial compounds like lignin and phenol. Since phenol is highly volatile, the heating process reduces or completely eliminates its functional antibacterial properties. In the conclusion, final finding, this research proves that bamboo charcoal extract at concentration of 12.5% to 62.5% has no inhibitory effect against Streptococcus mutans. For future research, I highly recommend exploring alternative processing methods that can be preserve the active compound of bamboo, combining it with other proven antibacterial agent, or performing chromatography or the measure the actual phenol levels precisely. That's enough for me. I apologize for the patient who have been waiting for me. Thank you and best wishes to all of us. Thank you.
Good morning, everyone. My name is Dr. Ifra Nasir, and I am an infectious diseases fellow at Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore, Pakistan. So today I will be presenting a case that sits in the intersection of oncology, infectious diseases, and otolaryngology. A case we published in Curious in January 2026. The title is Nocardia otomastoiditis in a chemotherapy-induced neutropenic patient with diffuse large B-cell lymphoma, successful medical management. So by the end of these 15 minutes, I want you to be able to do 4 things. First, recognize Nocardia otomastoiditis as a differential in any immunocompromised patient with chronic or refractory otorrhea. Yes. Particularly on active chemotherapy or corticosteroids. Second, note that modified acid-fast staining of an ear swab gives you the diagnosis before culture, often days earlier. Third, understand that trimethoprim sulfamethoxazole is effective and that treatment duration can be individualized based on disease localization and immune status. And fourth, appreciate that early diagnosis in this case completely eliminated the need for any surgical intervention. A 31-year-old woman, a 15-year-old ear problem, and a cancer diagnosis. When her first cycle of R-CHOP left her with 0 neutrophils, an absolute neutrophil count of 0, a forgotten pathogen found its moment. This is the story of how a single ear swab taken on the day she presented changed everything. Nocardia species are aerobic, filamentous, weakly acid-fast, gram-positive bacteria found in soil and water worldwide. Human infection occurs via inhalation or direct inoculation and predominantly affects immunocompromised hosts, particularly those on chemotherapy, corticosteroids, or following organ transplantation. Otologic involvement is so rare that only a handful of cases have ever been reported in the entire published literature. That is the published literature on Nocardia otomastoiditis, a handful of documented cases worldwide, and even fewer in patients actively receiving chemotherapy for hematologic malignancy. Pulmonary, cutaneous, and central nervous system diseases are the common manifestations of nocardiosis. Otologic diseases involving the external auditory canal, middle ear, or mastoid is exceedingly rare based on the available published literature and is frequently diagnosed late. Our case is one of the very few oncology-associated reports in the literature and one of the very few to achieve complete cure with medical therapy alone, without any surgical intervention. So our patient was a 31-year-old female with the non-diagnosis of gastric and pancreatic diffuse large B-cell lymphoma. She received her first cycle of R-CHOP, rituximab and cyclophosphamide, doxorubicin, vincristine, and prednisolone on the 31st of March 2025. She presented to us on the 9th of April. The ear history is important. She had suffered intermittent left-sided otorrhea for 15 years. Previous treatment with oral coimoxiclav provided only transient relief. No previous ear cultures have ever been sent. No imaging had ever been performed. The tympanic membrane was intact on examination. She denied any use of topical ear drops and had no occupational or environmental exposure to soil or organic material. On arrival, she was febrile at 38.5 degrees, tachycardic at 140 beats per minute, and hypotensive at 90/65, consistent with neutropenic sepsis. Her absolute neutrophil count was 0. Her CRP was 101.83 milligram per liter against a reference of less than 5. 2 sets of blood cultures were drawn, and both were sterile. Renal and hepatic function remained normal throughout her admission, which was critical because it allowed uninterrupted trimethoprim sulfamethoxazole therapy without dose adjustment. On the same day, she presented on 9th of April, an ear swab was taken. Figure 1 shows the gram stain. Filamentous beaded branching gram-positive rods viewed under oil immersion at 1,000 times magnification. This morphology is highly characteristic of Nocardia species. Figure 2 is the modified ZN stain. This demonstrated thin, branching, partially acid-fast organisms. Partial acid fastness is the key distinguishing feature of Nocardia from other filamentous bacteria, such as Actinomyces, which is non-acid fast. This single stain is what makes the diagnosis possible before culture. Figure 3 is the blood agar culture plate at day 5. Dry, chalky white, breadcrumb-like colonies, the classic macroscopic appearance of Nocardia after 72 hours of aerobic incubation at 37 degrees Celsius. Antimicrobial susceptibility testing confirmed sensitivity to trimethoprim sulfamethoxazole, ceftriaxone, tobramycin, and linezolid. Molecular species identification was not performed, a limitation we acknowledged in our published paper. A chest X-ray on April 14 showed complete clear lung fields. Pulmonary nocardia was, however, excluded, confirming localized disease. On the left is the baseline high-resolution CT of the temporal bone from April 10th. There is complete opacification of left mastoid ear cells and middle ear cavity, with soft tissue thickening around the auditory ossicles. Critically, there is no bony erosion and no intracranial extension. On the right is the same patient on the 2nd of September after 8 weeks of trimethoprim sulfamethoxazole. Near complete resolution, mastoid ear cells fully aerated, intact bony margins. What you see on the right is near complete radiologic resolution. That transformation from complete opacification to fully aerated cavities without a single surgical incision. So on April 9th, the day of presentation, empiric therapy was started. Intravenous imipenem at 500 milligram every 6 hours combined with oral trimethoprim sulfamethoxazole at 160 over 800 milligram twice daily, approximately 15 milligram per kg per day of the trimethoprim component. On April 10th, CT neuroimaging confirmed otomastoiditis without intracranial extension. This was the critical decision point. Once CNS involvement was excluded, imipenem was discontinued, and trimethoprim sulfamethoxazole monotherapy was continued, guided by susceptibility results. On April 13th, day 4, her absolute neutrophil count had recovered. She became afebrile by day 5. Otorrhea resolved and mastoid tenderness disappeared. She completed 8 weeks of cotrimoxazole. At 6-month follow-up in October 2025, she remained completely well. No recurrence of otorrhea, no systemic symptoms, no further episodes. No surgery, no mastoidectomy, no cranial intervention of any kind. So I want to contrast our outcome with what the literature tells us happens when diagnosis is delayed. In the case reported by Lee and colleagues in 2025, delayed recognition of Nocardia for Seneca otomastoiditis led to CNS spread, requiring mastoidectomy. So, Griginia and colleagues in 2025 reported a case in an immunocompetent adult where delayed diagnosis resulted in epidural abscess requiring cranial surgery. Cox and colleagues in 1986 reported a brain abscess following mastoid surgery in a child, a direct consequence of unrecognized nocardia. So, ICU admission, craniotomy, prolonged antimicrobial courses, and potential mortality. Now look at what happened on the left. Ear swab and modified ZN stain on day 1. Nocardia suspected before culture. Targeted therapy started immediately. CT excluded CNS extension. 8 weeks of trimethoprim sulfamethoxazole, cured, home, well at 6 months. One decision, the decision to stain, separated these two outcomes. So while this year, 15 years of chronic otorrhea created an established nidus and pre-existing vulnerable site, when Archop reduced her absolute neutrophil count to 0, phagocytic killing was abolished. Nocardia established itself in the mastoid. This is consistent with observation that most nocardia infections in the hematologic malignancy occur at sites of pre-existing local vulnerability. While localized and not disseminated, the immunosuppression was transient, not persistent. Her neutrophil count recovered by day 4. Early treatment contained the infection before CNS or pulmonary seeding could occur. Martinez has proposed that transient rather than persistent immunologic failure leads to organ-confined nocardiosis when treated promptly, and our case supports that hypothesis. So why 8 weeks and not 6 months? As per the conventional guidelines, which recommend 6 months for localized nocardiosis. However, in patients with confirmed immune recovery, localized, non-disseminated disease with a susceptible organism, shorter courses may be adequate. This is consistent with Marsh and colleagues in 2017 and Subha and Roman in 2004. The 6 months recommendation should be individualized rather than applied rigidly in every localized case. This table summarizes every reported case of Nocardia otomastoiditis in the published literature. So 10 cases included in total, including ours in this table mentioned. Look at the surgery column. 8 of the 9 previously reported cases required mastoidectomy or surgical drainage. In the 2 cases with intracranial extension, Griginia 2025 and Cox 1986, cranial surgery was also required. The single previous case managed without mastoidectomy, Salvo Gonzalo in 1996, involved an immunocompetent adult with acute mastoiditis media, a fundamentally different clinical scenario from us. So our case highlighted at the bottom is one of the very few cases of nocardia otomastoiditis in oncology patients receiving active chemotherapy to achieve complete cure with medical therapy alone, no surgery, and complete recovery. So first, think nocardia in any immunocompromised patient on chemotherapy or corticosteroids presenting with chronic or refractory otorrhea. Nocardia must be in the differential. Do not wait for any systemic feature. Localized disease occurs. Second, stain first. Modified acid-fast staining of the ear swab gives you the answer before the culture. Day 1 stain, drop day 1 therapy. That single decision is what prevented surgery in this case. Third, trimethoprim sulfamethoxazole works, but tailor the duration. 8 weeks was sufficient for localized, non-disseminated disease with immune recovery. The 6-month guideline should be individualized rather than applied rigidly, based on localization, susceptibility, and immune recovery. Fourth, early diagnosis eliminates the surgery. Most delayed or complicated cases in this literature required mastoidectomy or cranial surgery. Day 1 recognition here meant complete medical cure. No theater, no mastoidectomy, no craniotomy, no complications. Nocardia otomastoiditis is exceedingly rare, but it is not impossible. In the
Everyone, I'm Dr. Rashmi Prashant Rajshekar, Professor, Dr. D.Y. Patil Medical College, Pune. So I would be presenting on a very rare tumor of temporal bone, which we have not seen throughout of my 20 years of practice. So I'll be talking on management of giant cell tumor of the temporal bone with aesthetic repair of the bony defect. So giant cell tumor, it's a benign tumor which originates from undifferentiated mesenchymal cells of the bone marrow. Commonly involved sites are distal femur, proximal tibia, distal radius, and sacrum. Malignancy in giant cell tumor is rare. The cranium as well as temporal bone has a rare location for giant cell tumors. Also, it is very rare in pediatric age group. One second, have I shared my video? Is it compulsory to share? 1 minute, I'll just, yeah, it's open. Can you see the slides or is it stopped?
Your PowerPoint presentation
Is it okay? Fine. So 3% of tumors may become malignant, which has a very poor prognosis, and most of these tumors are treated by surgical method of management. And wide excision is desirable while it can lead to low recurrence rate. So despite the tumor being benign, it is locally aggressive and it has a high recurrence rate. Although all neoplasms of bone may contain giant cells, giant cell tumor of bone have a prominent proliferation of osteoclast type of giant cells. The stromal cells in giant cell tumor have molecular biologic features similar to those of osteoclasts. So now here I present to you a patient of a 46-year-old male patient who came to our ENT department OPD with the complaints of vertigo and headache since 2 months and ear discharge on the left side since 1 month. So the headache was of throbbing in nature and which was present throughout the day. It was not associated with fever or vomiting. Vertigo was intermittent and it was not related to change in his head position. The discharge was profuse, foul smelling, blood tinged and continuous. And it was scanty too. He also complained of insidious in onset of hearing loss and tinnitus. So, on examination of the ear, we found a pale pink fragile mass in the external auditory canal, which was totally occluding the view of the tympanic membrane. The mass did not bleed on probing and it was not pulsatile. While the fistula test was positive, there were no signs of any facial nerve palsy. Then we did a pure tone audiometry, which showed a conductive hearing loss of around 45 to 50 decibels, and a radio imaging, which is showing a osteolytic lesion of the temporal bone, which is measuring 3.5 by 2.5 by 2.8 centimeters of the left-sided temporal bone. We could also see that there was erosion of the glenoid fossa, left temporomandibular joint, roof of the left external auditory canal, anterior wall of left tympanic cavity, and tegment tympani. There was also focal extension of lesion into the left mesotympanum and a part of external auditory canal. Though there was no intracranial spread, there was also no extension into the infratemporal fossa. So these findings were suggestive of giant cell tumor or a plasmacytoma. So finally, we did a biopsy under otomicroscopy, and the biopsy histopathology showed cuboidal epithelium with mononuclear cells of fibrohistiocytes with osteoclast multinucleated giant cells. And hence, we posted this patient for the resection of temporal bone along with mastoidectomy. So, after doing all necessary investigations for the general anesthesia, the patient was intubated and he was operated for canal wall down mastoidectomy along with resection of the tumor from the temporal bone. So the post-auricular Weil's incision was taken, which was extended 2 centimeter anterior-superiorly and posterior-inferiorly, so that we could approach the temporal bone easily. And then posterior, after dissecting the temporalis muscle, mastoid part of the temporal bone was exposed and a mastoidectomy was done. So when the posterior myotomy was done, the tumor from the external auditory canal was excised. Here we can see on canal wall down mastoidectomy, we could not find any erosion of the facial canal. Also, there was a slight bony erosion of the bony labyrinth, while the endosteum layer of the labyrinth was intact and we could not find any erosion. While the ossicles were eroded, except 3.5 by around 2.5 growth in the temporal bone, which was excised carefully from the external dural sinus. And there was no intracranial spread also found on the intraoperatively. All after excision of the tumor, the bone margins were smoothened using the vulcanine burr. So usually what happens after removing this tumor, the wound is sutured and left it. Later on, once it is healed by fibrosis, there is a depression post-operatively, which gives a very bad look to the patient, and they feel socially very detached. They themselves make detached from the social events or functions. So what we did, we filled this huge gap with the abdominal fat, which was extracted from the periumbilical area. So this fat gave a good contour and aesthetic repair was given for this patient. Along with that, we did a type 3 tympanoplasty where we used temporalis fascia and a conchal cartilage for ossicular reconstruction. So on histopathology, we can see on the hematoxylin and eosinophilic stain, we can see the giant cells which are multinucleated and also which are surrounded by the spindled and stromal cells. So these giant cells are mononuclear cells. Mononuclear cells are the spindle cells or plump cell bodies which have moderate amount of cytoplasm. They also have a oval nuclei, while the giant cells are multinucleated and they are osteoclast type and they have the property of eroding the bone. Also, there are few studies which show that these giant cell tumor have the chance of converting into malignancy. Now coming to discussion, as they are osteoclastic in nature, they are aggressive. Though they are non-cancerous, they are aggressive. They are most commonly found in long bones of the upper and lower limbs. Giant cell tumors most often occur in young adults when skeletal bone growth is complete. So the exact cause actually remains unknown. The diagnostic test being the CT and MRI. Biopsy must be done before actually planning for the line of management, rather than getting confused with for the squamous cell carcinoma, which is the most commonest malignancy of the temporal bone. However, wide local excision of the tumor is usually the treatment of choice, but there are some studies where there is recurrence is possible. So there is also a role of adjuvant radiotherapy. Sometimes some studies say that radiotherapy is recommended for after the resection of the tumor. So it is used as a adjunct therapy. It is used as single modality treatment. Recurrence rates are up to 60 to 70%. It's given in 35 grays in 15 fractions or equivalent to that. Also, some authors report that radiotherapy itself may trigger sarcomatous transformation of GCT. So it's still a query whether to how much extent we can use this. There are few more studies where they show that tumor in the sphenoid bone, petrous part of the temporal bone, and middle cranial fossa. Sometimes in 1% of cases, it is seen that there are pulmonary metastases found in patients with giant cell tumor. So to conclude, a close association between clinical, radiological, and histopathological features is essential to make a definitive diagnosis of a rare tumor like giant cell tumor. Complete resection is possible for small and medium-sized tumors, and hence recurrence is very rare. And complete resection followed by filling the defect has maintained the contour of the temporal bone and has given a good aesthetic look for the patient post-operatively. Considering the benign nature of the tumor and the probability of malignant transformation after radiotherapy, surgical removal of the tumor remains the best management option. These were my references. Thank you. And I would acknowledge thanks to all my management, my dean, and my HOD. And thank you for the organizing committee to give an opportunity to participate in this.
Good morning, everyone. My name is Dr. Shazeb Sheikh. I'm a core surgical trainee here in Nottingham in the UK. And this was a dissertation or a dissertation that I did during my clinical anatomy year called Preventing Laryngeal Nerve Palsy During Thyroidectomies, a non-systematic review of the surgical anatomy literature, which was then later on published. So in terms of the presentation itself, I'll go through the introduction, the methods, the risk factors and mechanism of injury to the nerve itself, the main anatomical landmarks to identify the recurrent laryngeal nerve, and the main anatomical variations which increase the risk of laryngeal nerve palsy. So as an introduction, the recurrent laryngeal nerve, it's the nerve that basically supplies all the laryngeal muscles except the cricothyroid, and this is important for swallowing, phonation, and breathing. So the nerve's anatomical course can vary bilaterally. So on the right side, it loops under the subclavian artery, whilst on the left, it loops under the aortic arch. But this nerve is very prone to damage during thyroidectomy due to its anatomical course and due to its close proximity to nearby thyroid structures. And this causes a risk of recurrent laryngeal nerve palsy. So in terms of our methods for the literature review, we did a literature search using PubMed and Medline, and we applied Boolean operators with keywords related to recurrent laryngeal nerve variations, so like anatomical landmarks. We put in thyroidectomy, Berry's ligament, and Zucker-Candle tubercle, and various other Boolean operators. So multiple keyword combinations were used depending on the anatomical landmark or injury prevention method being investigated, and we included journal articles, systematic reviews, and meta-analyses. We identified the top 40 abstracts from each search, which were then screened for relevance, and selected papers and citations from meta-analyses were reviewed further as well. Dissertations, letters to authors, and conference literature were excluded from the literature review. So, in terms of the main risk factors, we found that essentially recurrent or repeat goiter operations and malignancy or malignant goiters had the higher outcomes of recurrent laryngeal nerve palsy. And this is because there is an increased risk of adhesion and scarring, which makes it difficult to view and then dissect the nerve. And carcinoma, obviously invades surrounding tissue, which again distorts the local anatomy and causes a difficult dissection. So these two were found in the literature to be the main risk factors for recurrent laryngeal nerve palsy. In terms of the main mechanism of injury itself, so traction and thermal injuries had the highest prevalence, with traction having almost 71% prevalence of injury. Now, traction is obviously very quite common during thyroidectomy. So obviously when doing dissection of the nerve itself and pulling on the nerve, that is obviously, it has the highest prevalence due to the fact that it's, done, I guess, it's commonly done during intraoperatively. So in the main anatomical landmarks, so the first one is the tracheoesophageal groove to try and identify the nerve. So what this groove basically is, so the trachea and esophagus, when it butts together, it forms this indentation. So it forms this basically groove in between the two. Now in the literature, the nerve is found within the groove in about 63.7% of cases and outside in about 36%. And this is statistically significant according to a lot of the meta-analyses that have been done. Now, some studies say that the nerve is in the groove more frequently, well, inside the groove on the left side than the right side, but there is no statistically significant difference between this. Now, if the nerve itself is found outside of the groove, it's found in this. So if you see in the figure 1 here, there's different positions where it can be found in relation to the groove itself. So if it's not in the groove, it will either be anterior, anterolateral, lateral, or posterior. And it's found anterior in about 45% of the time. Now, this actually has a high significance of devascularization to the parathyroid glands. And there is a risk of ligature to the nerve itself if it is found to be anterior or lateral to the tracheoesophageal groove. So overall, this is a less reliable landmark due to its inconsistency, particularly when it's located outside. So this is some dissections that we did as part of when I did my dissertation. So on the left side, you can see that the nerve is inside the groove, and on the right side, we found that it was anterolateral in one of the cadavers that we dissected. So the Berry's ligament, so this is a suspensory ligament, which is made of pretracheal fascia, and this anchors the thyroid gland to the laryngeotracheal complex. There are 3 common relationships between the nerve and the Berry's ligament that have been found. So it's either the nerve is superficial, so either deep to the Berry's ligament, or it's piercing the ligament. Now, many studies say that in 100% of the time that the nerve is superficial to the ligament, but other studies say that this is only 50% of the time. Now, sometimes this disparity is explained by a superficial vascular layer and a deep avascular layer, which is the true Berry's ligament. And a lot of studies may not have accounted for these layers when reporting the prevalence of the relationship. But overall, the literature says that this is quite a reliable landmark to use due to its high sort of consistency of the nerve being superficial to the Berry's ligament. And it's especially useful for large substernal goiters which are accessed superiorly. So the Zucker-Candle tubercle, this is basically like a lateral protuberance from the posterior part of the thyroid gland, and this is thought to be an embryological remnant. Now, what this does is it basically acts like an anatomical arrow. So it basically allows quite easy identification of the nerve. And that's because almost 80% of recurrent laryngeal nerves are found posterior medial to the Zucker-Candle tubercle. And in studies, when they did, I think, was it intraoperative cases or even cadaveric studies, they found that in 100% of cases, it led to identification of the nerve itself, and it actually acts as a protection against injury. But then other studies have shown that actually there is a high risk of thrombosis and hypocalcemia due to devascularization of parathyroids in the region, and an enlarged thyroid itself can actually mimic a Zucker-Candle tubercle, which can actually cause displacement of the nerve itself. But overall, this is considered to be a reliable landmark due to the consistent relationship again between the nerve and this Zucker-Candle tubercle. And this is how it basically looks like. So you can see the thyroid gland and this protuberance coming out, and then just posterior medial to it, you can see the the recurrent laryngeal nerve to it. So the inferior thyroid artery, this basically has a very highly variable relationship to the nerve. Most commonly, it's found either the nerve is anterior to it, it's either posterior to it, or the nerve intertwines the inferior thyroid artery. On the left side, the nerve is commonly found posterior, whereas on the right side, the nerve is more commonly found to be anterior or intertwined. But then this actually has a higher risk of recurrent laryngeal nerve palsy, as because when the nerve is stretched, the nerve can be stretched a lot more easily when the gland is mobilized anteriorly. So if it's obviously anterior to the artery, when you're stretching the nerve, when you're mobilizing the gland anteriorly, this causes increased stretching of the nerve. So one of the studies by Yeltsin et al. He says that essentially the artery as a landmark is not really that useful because there's a high prevalence of the intertwining position. There's a high risk of cauterization and forcey pressure, or risks of forcey pressure and cauterization to the nerve itself when obviously dissecting the artery around in that region. But Tonitato et al. Says that basically what you can do is you can use like a loop around the artery, you can encircle it, and when you apply tension on the artery, that can actually allow easy identification of the recurrent laryngeal nerve itself. However, there is a lot of selection bias in these studies for the inferior thyroid artery, and a lot of demographic factors may actually influence a lot of these rates, which have not been accounted for in a lot of these studies. And this is an hour dissection. We found on the right side, the nerve was found anterior to the inferior thyroid artery on the right side. So in terms of the main anatomical variations, so the first one is extralaryngeal branching. So this is where the nerve itself branches near the laryngeal entry point. This is found in up to 60% of cases and 37% bilaterally. So bifurcation, which is where it splits into two, is the most common variant. So you have the two main branches. So the anterior branch carries the main motor supply to the laryngeal muscles, whereas the posterior branch is the branch that carries sensory information to the mucosa beneath the larynx. Now, the issue is that the posterior sensory branch is larger, and it's usually the branch that's assumed to be the only branch, because the anterior branch usually is quite more smaller. But this is obviously the most important branch because it carries the motor supply. So unintentionally, the literature has found that the anterior branch can be commonly transacted, or traction injuries can be applied to it. And there is this again causes a high risk of palsy. And overall, there's a 3% higher risk of recurrent laryngeal palsy in branched nerves compared to unbranched. And then another common variation is the non-recurrent laryngeal nerve. So this is where actually the nerve doesn't actually branch underneath the aorta or the subclavian artery. This is associated also with the rare embryological abnormality on the right side called the Lusoria artery. Lusoria artery. This is where the subclavian artery, instead of arising from the brachiocephalic trunk, it arises directly from the aortic arch. This can be often seen unexpectedly during thyroidectomy without any prior suspicion. It can be easily misidentified as the inferior thyroid artery, which again causes trauma to the nerve itself or compression injuries. But there are a few cases where you can potentially suspect whether a patient might have the non-recurrent laryngeal nerve. And this is where if they have a right-sided thyroid mass, if they have dysphagia, if they have an abnormal chest x-ray with anomalous vasculature. And the literature has found that imaging modalities, so like ultrasound, CT scans, can be used to used preoperatively to predict this non-recurrent laryngeal nerve. And actually, this can reduce the chance of palsy by 75%. And this is in an image or an example of the non-recurrent laryngeal nerve in one of the studies. So in conclusion, the main risk factors are malignancy and goiters. The main mechanisms of injury are thermal and traction injuries. The literature found that the Zuckerkandel tubule and the Berry's ligament are the most consistent in their relationship with the recurrent laryngeal nerve, and hence should be more commonly used by thyroid surgeons. Whereas the tracheoesophageal groove and the inferior thyroid artery, because of their many different relationships, they have a less reliability as use of landmarks. In terms of the main variations that thyroid surgeons need to be aware of is extralaryngeal branching and the non-recurrent laryngeal nerve, as this is clinically associated with recurrent laryngeal nerve palsy. But overall, all of these studies and all of these, in all the meta-analyses and the systematic reviews, essentially we need further studies with larger sample sizes with larger randomized cohorts in order to produce a lot of the biases that have been shown and establish the clinical outcomes and uses of these main landmarks and the variations itself. So these were some of the references that we used. And thank you. Yeah, so this is an audit called Same Day Elective ENT Theatre Cancellations across 3 hospital sites in United Lincolnshire Hospitals Trust. Yeah, so one second. It's not letting me. Okay. Yeah, so as an introduction, same-day elective theatre cancellations result in a lot of patient distress, a loss of confidence for patients, an inefficient use of theatre time, and an increased risk of referral to treatment breaches. ENT is obviously a high-volume elective surgical specialty, and there is a national focus here in the UK on elective recovery and theatre efficiency. So why this matters is that cancelled theatre time on the day is rarely can be recoverable, and identifying avoidable causes for cancellation is essential for service improvement. So in terms of the main standards and guidance, our trust, so the hospital trust elective access policy, is that elective cancellations should be avoided wherever possible, non-clinical cancellations should be rebooked within 28 days, and robust pre-operative planning is required. The Royal College of Surgeons, they say that avoidable same-day cancellations are unacceptable and senior-led theatre planning is highly recommended. The GIRFT, which is the Get It Right First Time, this is a UK NHS sort of national scheme. They say that the list overruns, it basically reflects system and scheduling failures. ENT UK, which is the sort of national body in the UK which represents ENT surgeons and gives advice and guidance, they say that case complexity should be considered when designing a lot of these theatre lists. So our aims and objectives from this audit the aim was to identify causes of same-day elective theatre cancellations in 3 hospitals in the trust, and the objectives were to assess whether these cancellations were avoidable, to benchmark practice against trust and national guidance, and to identify realistic short-term interventions for improvement. In terms of the methods of the audit, this was a retrospective audit, and we had 3 hospital sites within the trust. So we included all same-day elective ENT cancellations from July to November 2025. And we analyzed 47 cases in total. These cancellation reasons were grouped into 5 main categories. So if there were list overruns, unfit for procedure, inadequate preoperative preparation, staff unavailability, or if the hospital cancelled themselves, or if they need like a bed. So basically a specialist bed, a HDU bed or something. Each cancellation was also classified as avoidable or unavoidable. Our inclusion criteria included same-day cancellations and elective operations. Exclusion criteria were emergencies, patient reasons if they themselves did not attend or refused, if the surgeon was unavailable due to like an emergency or something, or if the hospital cancelled for an administrative reason. So in terms of the main cancellation reasons, we found that over half of all cancellations were due to the list itself being overrun. And in terms of the cancellations by site, so we have 3 hospitals in the trust. We have Lincoln, Pilgrim, and Grantham, Lincoln being the largest hospital. So in terms of the total number of operations that they had in that same time period from July to November 2025, Lincoln had the highest number of cancellations at 7.4%, compared to Pilgrim and Grantham at 5.5% and Grantham at 3.15%. So majority of these cancellations occurred at the largest site, and this suggests that there is a system-level pressure rather than isolated events. So in terms of avoidable versus unavoidable cancellations, we classified the avoidable cancellations as almost 36 or 77% of all these cases. Unavoidable were only 11. So the avoidable causes were like list overruns, inadequate pre-op preparation, and some staffing-related cancellations. The unavoidable causes were like if there was an acute illness, medical unfitness, bed availability due to acute pressures. And in terms of like from the guidelines, so the Royal College of Surgeons and the Get It Right First Time, they, as I said before, they identify list overruns as modifiable system failures. So the key problem that we identified was basically list overruns, which accounted for 51% of cancellations. This could be due to the fact that there is an underestimation of case complexity, there is unrealistic list scheduling, limited senior review of lists before the day of surgery, And yeah, so national guidance recommends that there should be senior-led list planning, and complex cases should not be clustered together without having a buffer time. So having, for example, like 4 thyroidectomies in one day, shouldn't just be clustered together without having some buffer time. And this is what we were finding in our hospital, that a lot of these very complicated cases, a lot of them like mastoidectomy with a thyroidectomy with, very long cases, complex cases were just clustered together, which eventually then were leading to a lot of cancellations because of it being overrun. So conclusions from the actual audit itself, we found same-day ENT theatre cancellations remain, really common. Majority are avoidable, and list overruns are the dominant cause. Our next steps were to implement a targeted intervention focusing on list planning and improve documentation of cancellation outcomes, and to re-audit after 1 month to assess the impact. This targeting list overruns offers the greatest opportunity to reduce avoidable cancellations and improve patient experience. So in terms of our recommendations for this audit, we recommended that number one, there should be a senior review of theatre lists around 48 to 72 hours pre-list, and the consultant or the senior registrar, they should review the list feasibility in advance. Number two, there should be a case complexity stratification. So these cases should be basically simply classified whether they're low, moderate, or high complexity. This is to allow multiple high complexity cases to be basically avoided being booked on the same list. And so, the sort of department, what do you call them again? The people in the department who basically assign these who basically make these theatre lists, they know to not classify these high and moderate cases and cluster them all together. And there should be a built-in buffer time for complex lists. So especially for like afternoon or mixed elective lists, there should be a bit of buffer time in between. And usually that includes like the anesthetic sort of time as well, the time to anesthetic. So we want to essentially build in sort of a buffer time as well. There should be a preoperative readiness check, so confirmation of fitness, investigations, and consent with the patient before the fact that they come on the day on the theatre list itself. And finally, there should be mandatory documentation of the cancellation outcome. So why was it, what was the reason for cancellation? Was it avoidable? And having a rebooking plan. So all these interventions are achievable within 1 month or so. There's minimal cost and it aligns with trust and national guidance. So as of now, we are basically trying to get these recommendations onto basically the form. So in terms of the case complexity stratification, basically we decided to do that on a specific form that the ENT surgeons, when they see patients in clinic, they can already classify these cases, which then get sent to the department, like the theatre schedulers, etc. So they can then classify or make the theatre list based on the complexity stratification that the senior registrars or consultants have done in the clinic. So we're basically waiting for that to be now implemented, and hopefully we'll be re-auditing within 1 month or so, or a couple of months or so, and seeing what the outcome of the audit is. So these are the references that we use. So thank you very much for listening.